We are starting off the day with a kickstart. Dyskinesias as tremors, dystonia, and myoclonus are fascinating clinical presentations. And a glimpse of abnormal movement will be our first plenary for the day.
I would like to invite the chairperson, Dr. Ranjan Dias, to commence the symposium on surgery.
I'm sorry, I would like to invite Chairperson of the Plenary on Neurology, Dr. Champika Gunawardena, to commence the session.
Good morning. The speaker, Dr. Darshana Sirisena, no need any introduction. He's from here, Ratnapura, and he's very well connected to Ratnapura. But for the formality, I will make a small introduction. Dr. Darshana Sirisena, consultant neurologist, teaching hospital Ratnapura. He has graduated from Faculty of Medicine, University of Kelaniya, and had done postgraduate qualifications from University of Colombo. And fellowship was done in Monash University of Melbourne on movement disorders. He is the current president of Sri Lankan Association of Neurologists. He will take over.
Thank you all. Good morning. And at the outset, I should thank the President and the Council of the Ratnapura Clinical Society for inviting me to give this lecture, especially my dear friend Dr. Champika Gunawardena. So I think Ratnapura is a very close place to me, where I started my career as an intern, and thereafter about 3-4 years as a post-intern, before moving to postgraduate studies. So a lot of familiar faces. Actually, it seems that I'm coming back to my home, right? So to start, without much ado, I'll start my talk because of the interest of time. The talk is going to be on glimpse of abnormal movements. So this talk was forced to me by my friend Champika. So the topic is his, right? So when it comes to neurology, we are very fair people. You know, looking at Champika, we are very fair people. So I'm going to discuss about 20 cases. So if the time's up, please give me let me know. So next 2 slides, I'm going to show you all the cases I'm going to show you. So what you need to pick and say, this is this, right? Very simple. So when it comes to the movement disorders, there are 2 broad types. One thing is in your right, that is the hypokinetic. As the name implies, hypo is less, kinetic is movement, so less movements. When it comes to less movements, only 2 conditions you need to know. It's Parkinsonism. Don't ever think about anything else, it's Parkinsonism. Or Parkinsonism could be idiopathic, which is the vast majority. The rest could be atypical. So if you can think about Parkinsonism, that is more than enough. Leave the rest to the neurologists. When it comes to hyperkinetic movement disorders, that is, as the name implies, hyper is excess, kinetic is excessive movement. So there are, if you go for the textbooks, there may be more than 100 entities, but you need to know is about 5. What are those? Chorea, dystonia, myoclonus, tics, and tremors, as told in the introduction. Majority of the cases fits into that. So to make the things matters much easier, I am giving all the definitions for you also. So can you see? So all the definitions, if the case I am going to present fits into this, that is the diagnosis. So tremor, as you all know, is one of the commonest movement disorders. It's an oscillatory, it's a rotational movement, very rhythmic, right? And very regular of a part of the body, maybe the hand, maybe the neck, maybe the tongue, or whatever the body part. So when it comes to the next one, the chorea, it's totally opposing the tremor. It is involuntary. For that matter, all these movements are involuntary, very irregular, purposeless. Sometimes the people might show that they are doing for a purpose, non-rhythmic, abrupt, very unsustained. So if you think about this very unsustained movement that flow from one body part to the other, which is not there in the tremor. And thirdly, myoclonus. Myoclonus is very brief, jerk-like movements, right? The 4th one is dystonia. I think you can see, no, from the back. The myoclonus, the dystonia is, when compared to chorea, see, abnormal, very sustained, prolonged. When it comes to chorea, it's a very brief episode, posturing of a part of the body. So tics is the other thing that you should know. It's abnormal movements. Sometimes it could be vocal as well, which is called as phonic tics. So these are the 5 things you would know. So we'll go ahead. So this is famous. The first principle I'm going to teach you, which is abnormal, which is normal. Isn't it simple? This is famous Michael Jackson in the dancers and a patient. So don't video all these patients, I have not covered their faces, right? So this patient is doing, the Michael Jackson is doing for a voluntary, right? When it comes to this lady, it's involuntary. So that means this is physiological and that is pathological. Very simple, isn't it? Right. So with this background, this is the first thing I want to show in the movement disorders. So case number 1. So I have a lot of phases which I know the names, so better commands, otherwise I have to show and get the answers. Consultants are exempted, that is the advantage of being a consultant, right? So 54-year-old football coach, actually from a very leading school, presented with involuntary movements of both hands. So question is, what is the neurological diagnosis? And in order to come to diagnose, what other clinical signs you need to exclude? Anybody? If you are quick, I can go all the 20 cases. Put it to the eyes, put a slide. Anybody? You can make mistakes, don't worry. Making mistakes, we are here, right? Once more, that's all. It's very rhythmic, isn't it? Very regular. And it's a rotational movement. What it is? It's a tremor, right? Very simple, it's a tremor. But the important thing is, when a tremor, you have to tell in what position it's worse. So here in this patient is at rest when the gravity is eliminated and the patient is well resting his hands. So the diagnosis is patient rest tremor, tremor at rest. What are the clinical signs you need to elicit? Yeah, right. Tremor at rest. But I told you, if the patient has a tremor at rest, the clinical pill I am going to give you, it's Parkinsonism unless otherwise proven. So what are the other 2 signs of Parkinsonism? The bradykinesia and the rigidity. So you need to see. Yes. So what is bradykinesia? Again, is weakness. Bradykinesia, if you could see, we do repetitive movements. With the repetitive movements, the velocity or the things, it's getting worse. So when you start, it starts like this and gets slow. Weakness is not such, right? You ask to do the finger taps, start with better and comes back. So if these signs are there, there is no rocket science here. It is Parkinson's disease or Parkinsonism. All clear? So don't miss this one. So simple diagnosis. Myself and Champika seeing patients being managed for various other reasons, for thinking of various other etiologies. So this is because we can manage these patients very well with our facility. So the condition is Parkinson's. Right, the message I want to give you here, idiopathic Parkinson's disease, 3 things you need to know. The akinesia, the correct term should be bradykinesia, but for the interest of the mnemonic, akinesia, there's lack of movements or slowness of movements. Rigidity, which is extrapyramidal rigidity, either could be cogwheel or the clasp knife, the tremor at rest. The important thing is sometimes the patient doesn't have tremor. They come as bradykinesia, it's a co-feature. So you have to think about it. Slowness of movements, always think about idiopathic Parkinson's disease, nothing else. Okay. It's a 28-year-old female. So presented with abnormal movements. What is the diagnosis? And I have given huge clue in the 3rd thing. Patient had abnormal liver function test as well. If you miss this also, this is a crime. Anybody? I'll put another again. It's very rhythmic, isn't it? Very regular. So it's a tremor. Important thing in what circumstance? Anybody? Excellent, right? So this is called wing beating. So patient is trying to fly. So this is very characteristic of a wing beating tremor, and the condition is Wilson's disease. Okay? Do you need to show me again? So always when you come across a patient with tremor, always try to do all the maneuvers, right? Ask the patient to keep in posture and see whether the postural. This position, then you can get the wing beating and the intention path. Okay. All right. This is a wing beating tremor of a Wilson's disease. Okay. So look at this patient, 64-year-old male. Actually, the patient gone to ENT surgeon, mentioning that patient has a clicking sound in his ear. I'll show it again. And then after doing all the investigations sent to us, after, when they opened the mouth, they saw something very regular, very rhythmic. So again, it's a tremor. But what tremor is it? Where is the tremor? It's a palatal tremor, very simple. But the issue here is the clicking sound. When it's a clicking sound, that you have to see there are two varieties of palatal tremor. One is called essential palatal tremor, other one is called symptomatic palatal tremor. The essential tremor is very benign because of the contraction of the tensor palatini, the eustachian tube open and closes, making a clicking sound, which is very localized condition, very benign. But there is another condition called symptomatic palatal tremor. There is a very famous area in the brain called Guillian-Monroe triangle, the red nucleus, the inferior olivus, and the dentate. So all these connected medulla, cerebellum, and other connections. If you come out without a clicking sound of these patients, like a tremor like this, it's almost always pathological, and always we have to look for a space occupying lesion in those regions. Okay? So the correct diagnosis will be essential palatal tremor. Now, I am going to the next one. So I discussed various aspects of tremors. Then I am going to this one. Just check and let me know what movement disorder phenomenology. All these tremors and those things are called as phenomenology. So first thing, when you come across a patient with movement disorders, what you need to identify what phenomenon this patient has. Okay, look at. Video is a little long, so I'll skip. Yes. Look at this and try to describe. Is it regular? No. It's very irregular. And you see, you can't predict what is going to happen next. Go through the video, right? This flows from one part of the body to the other when you go through the whole video, right? Anybody? Even the patient is walking, you could see certain movement. It starts from the neck, it goes to the hands and then legs, whole body is involved. Can you see? So what's this? Very silent. It's a chorea. So it's a patient with chorea, right? So what I want to show you is the phenomenon of chorea. The patient is very regular, very abrupt, involuntary, passes from one part of the body to the other, right? Flows, right? Okay. So coming back. So the diagnosis is the patient has chorea. Now this one. Actually, this patient was referred to me by, who is in the audience when I was working in Badulla, Dr. Sirisena A. So what is the diagnosis? That's the thing. Do you all agree this patient has chorea? Just look at Sensei. So when Sirisena sends to me a patient, so there is pregnancy. So connect those two. That's very simple. What is this? It's not nice to ask from Sirisena. He knows the diagnosis, that's right. This is a chorea gravidarum, right? This is called chorea gravidarum. The etiology is not pregnancy actually. This is the patient have pre-existing rheumatoid carditis and other things. Unfortunately, it's precipitated during the pregnancy. So this is a condition in chorea gravidarum, right? Okay. Right. What neurological condition these two siblings are suffering from? His sister and younger brother. What I want is a diagnosis. I'm sure you have to entertain the patient as coriform movements, isn't it? So very regular, flows from what part? So what is the neurological condition? Anybody? You can loud. Pain it na, just go ahead. Like you are seeing for the first time. You should go for a rotation to the Champika's clinic, I think. What is this? The female, the elder sister is being treated, that's why the movements are very much less. But what I want to show is both siblings. This is what this is. It's a genetic condition, very pretty obvious. Yes, Huntington's, it is Huntington's disease by the mitochondrial condition, inherited by mitochondrial. So it's a tri-repeat sequence, trinucleotide tri-repeat sequence, CAG, right? More than 37 alleles. So this is a condition, what we call as Huntington's disease. Okay. So just observe this patient, right? This is an elderly lady coming with, just observe. Neurology is always observation, right? If you are not blind, you should be able to diagnose. That is why myself and Champika is doing neurology. Careful observation. The question is what neurological phenomenon this lady has and what are the two common etiologies you come across each and every day. I'll show it again. Just see whether it's a very regular or irregular, whether it's rhythmic or abnormal, and what part of the body involved. So definitely only one part of the body is on the left. If you say the left upper limb, and I'll help you. It's like very giving away, like what we call as ballistic-like movements, right? Very simple. So one half of the body is involved with ballistic-type movements. So what is the condition? Correct, hemibellism. This is called hemibellism. What are the two etiologies you need to come across? So immediately when a patient comes, I am sure you are seeing enough and more patients. We get about 10-15 referrals per year from medical wards. One thing is always suspect if a patient comes with acute onset basal ganglia infarct, always. The second thing is hyperglycemia. We call this can be hemichoria as well, right? The hemichoria term is also good. These are coriform movements. The non-ketotic hyperglycemia. Sometimes patient comes, you do immediately do a blood sugar, random blood sugar, maybe 400-500 most of the time, right? What you need to show, it's unilateral, so it's only unilateral. So hemicide, there's another hemichoria hemibellism, basal ganglia infarct. Okay. Next one, what neurological disorder these two people are having? Actually, the sounds is not there. That's in the female. So what movements? Look at here and look carefully. Very simple. Now I have done 2 cases, so only 3 is left, 3 diagnoses left. Very abrupt, isn't it? Very abrupted, abnormal movements. Actually, this lady, the weed sounds is not damn sorry for that, has some vocalization also, making some sound, like almost some shouting and other things. Very simple. What is the diagnosis? I'm sure many of you have seen these patients. It's tic disorders, right? These are tics actually. These are tic disorders. Right, these tic disorders. So that is a diagnosis. Right. So the important thing is when the patient has sometimes why not disease GTS, the Gilles-Dillard Tourette. Yes, the patient has vocal and phonic tics both. For a certain period of time, GTS. Otherwise, the motor tics alone doesn't fit into GTS. I have seen many patients being diagnosed as GTS with motor tics. No, it's not. So it's the umbrella term for these called tic disorders. They might have simple motor tics, very complex motor tics, simple phonic, and very, very very filthy words. Actually, very seen so like lot of complex ones. So these are tic disorder. The important message also, I have seen many patients of such, because this is very common in children, started on many antipsychotics. Don't do that. These patients, just reassurance for the patients if they are simple enough, right? Most of the time what happens if they are socially embarrassing, just tell them, because when you are stressed up, the patient asks the patient not to do, he gets more stressed out and this is getting worse. So careful if the patients, educate the patients, parents and the teachers might be the best treatment for these patients, not starting any treatment. I think we are seeing many patients, maybe if I come 10, I am not starting for a single patient even, just reassurance, if not troubling them a lot, right? Considering this, you might think it's a children's pediatric disorder. No, tics can be seen in adults as well, right? So adult onset tic disorders. You can see the blinking and all these facial movements. Okay. Right. Another 10 to go. Right, very good. Look at this child. So the history is the 3-year-old boy has a feature of viral encephalitis and get recurrent seizures. Look at the perioral or the mouth. It's very characteristic, this condition. Where if you see this one, these are diagnosed, you can save the life, otherwise the patient is going to die. You can observe the perioral region. They have very dyskinetic movements involving the oral, buccal and the lingual region, like what's called rabbit faces also. They're trying to, like a face of a rabbit, right? So what is this? I want the condition. Anybody? I'm sure you have seen. Udayangan is trying to tell something? Yeah. Excellent. This is autoimmune encephalitis. Don't miss this, please. because earlier the treatment survival is much, much better. Otherwise, patient is going dying. So what is characteristic again, I'll show you. So the perioral. To be more specific of this one, so if you want to more specific, this is called anti-NMDA receptor antibody positive encephalitis, right? So the treatment is IV steroids at IV methylprednisolone, failing upon IV immunoglobulin and plasmapheresis. So very, very rewarding thing, but if you diagnose early, so the diagnose autoimmune encephalitis, right? The more specific, anti-NMDA receptor antibody positive encephalitis. What I am showing is actually about 10 years ago, this diagnosis was not entertained. Actually, we didn't know about that. Because of that, I missed this patient when I was in Anuradhapura, and this patient passed away. Right? So this is why. Very characteristic. It's very pathetic. So this came to the field in about 6-7 years ago. Now freely available, these anti-NMD receptor antibodies, even the government sector up to now is available. So this was in Anuradhapura. So this is the patient. So very characteristic movements. Actually, this came to the knowing, if you have Netflix, you go and see there is a movie called Brain on Fire. It's a very nice film on a journalist who was diagnosed of this one. So all the things going for psychiatric unit from this to that, right? Ultimately diagnosed. Okay. Good. The case 11, we are halfway there. What is the diagnosis? Very simple. If you went through the definitions I gave, very simple. Look, yeah. Very brief, like a person being electrocuted, right? So what is the diagnosis? It's myoclonus, right? These are myoclonic jerks, actually. When it's like very sudden, brief jerks, those is myoclonic. What are the conditions you know of? Myoclonus could be divided into three things: the cortical myoclonus, subcortical, which into the brainstem and other areas, and the spinal myoclonus. So this is as the body, whole body is involved. This is more or less general myoclonus. Always consider epilepsy. Number one diagnosis is epilepsy. The other one is very common, is the uremic encephalopathies, can present in this way. For that matter, any encephalopathy, but the commonest is the uremic encephalopathy. Right. Look at this patient. This patient came to me, actually this video is from courtesy of Dr. Pyara Ratnayaka, pediatric neurologist at LRH. This patient, the boy was hammered by teachers, parents and everybody by putting when he holds into something, putting the objects down. Suddenly drops. He couldn't keep the muscle tone intact. Sorry? Cerebellum. No. Cerebellum is usually intention tremor and like this. This is another form of myoclonus. This patient had epilepsy, right? So it's called, the positive myoclonus is like this, goes up. Here, can you see it drops down. This is a negative myoclonus, right? This child kid's hat, can you see? He couldn't see. So this is another case of myoclonus, which is negative myoclonus, and this patient had epilepsy. When we did the EEG, found to have this one. Okay, we'll move. Right. I don't think even you need to watch the video. You can tell the diagnosis from now. So what is the diagnosis? What neurological condition or phenomenon this patient is suffering from? Is it the position is abnormal? Is it? Do you agree with that one? It is sustained. So, abnormal sustained posturing of part of the body. So, what's the diagnosis? It's a dystonia. What part of the body is involved? It's the neck. So, what is the medical term for the neck? Cervical. So, this patient is having cervical dystonia. Isn't it? So, very simple, isn't it? That's why I told neurology is very simple. Unfortunately, many doesn't understand that. So, okay. So now I'm going to show another video. Even with that, you can tell the diagnosis now. But look at the video. Patient has another thing in the patient. In addition to the abnormal posturing, patient has a very rhythmic movement. So, titubation. Titubation is another tremor, and actually there are 3 clinical signs. She is showing another one. This is very diagnostic. Dystonia is there, do you agree? And a very rhythmic movement. So, patient has a tremor. This is a combination of a dystonic neck tremor. The most important thing I am showing the video again, right? So, very rhythmic movement, dystonic neck tremor. And the important thing, if you are suspect, ask the patient whether there is any maneuver, any trick that makes the patient better. So, the patient told, when I am doing like this, it's much better. So, which we call it a sensory trick. It's very diagnostic of a cervical dystonia or a dystonic cervical dystonia. So, diagnosis is cervical dystonic neck tremor, right? I'm sure you are coming across a lot of patients like this, just to know the stuff, that's all. Okay, we'll go to the thing in interest of time. See what these two, the lady and the male has. Again, just observe. Again, observe just what, is it the entire face, in all his face, is it entire face or half of the face? So what sort of little bit of twitchy movements, isn't it? What we call as spasms, right? So diagnosis is already there. And why I'm asking, as the answer is very simple, I'm asking what is the best mode of treatment as well. Any eye surgeons around? Because these patients usually go to the eye surgeon. This hemifacial spasm, another form of focal dystonia, another form of, because it's sustained posturing of a part, but it's more twitchy, right? So what is the best mode of treatment? Yes, excellent. This is intramuscular Botox. You can completely relieve the condition, right? Okay. Case 15, just look at, I think I can go for 20, 30 minutes, no? 30, yes. Look at here. Again, observation, nothing but, have I done any fancy investigations here, MRIs and other? No, none, right? The patient has, again, some sort of a movements in the face, which is bilateral in the face. And in addition, if you look carefully, patient has movements around the neck as well, right? So there is a characteristic name for this one. That's why I put this case. So this is called craniocervical dystonia. The correct, this was invented by one famous person, so it's under his name. It's called, there is a same name is there for the ovarian condition also. I know now. It's called Meg syndrome, right? This is called in neurology, not the gynae one. This is the Meg syndrome. So the issue is the patient has bilateral spasms as involvement of the neck. So cranial as well as cervical. So craniocervical dystonia or Meg syndrome. The treatment again is Botox for this one, botulinum toxin. So just go through and see what neurological condition this patient is suffering. You know, he came to me, he couldn't see. He was a driver, he couldn't see. Eyes are closed, what we call as a functional blindness, right? So what neurological condition actually you can name two. You have to examine carefully to see, differentiate each other. Now what I'm asking, ask the patient to, he can't open, so I'm asking to open it by, then it's fine. So the power is there, but the muscle power is all there. That's why he can maintain the thing after opening. So it's called apraxia, right? It's apraxia. When an eyelid is involved, we call it as eyelid apraxia. This is a condition of eyelid apraxia. And this is sometimes, I showed you a hemifacial SAMS. There is a condition called blepharospasm. When both eyes are involved, we call as bilateral essential blepharospasm. That is also can be entertained as a differential diagnosis, but they are more spasmodic. So I would go for this one as eyelid apraxia, right? Always ask the patient and ask to keep, then he could keep the eyes open. Okay. Okay, this is a nightmare for general practitioner. Oh, diagnosis. Sorry. The girl presented the abnormal movements after getting treatment for vomiting. So look. Unfortunately, this is not known. There are, but very few because this offending drug is not used much like those days. Look at the eyes. This is called stargazing appearance. Right? It's called stargazing appearance, looking up. Maybe within hours of giving this, the treatment is metoclopramide, right? So, what is this condition? Patient like is it true, right? Your practice is gone. So, it's oculogyric crisis, secondary to metoclopramide. Right? And you see the rotational movements, the torticollis of the neck, as well as the stargaze appearance of the eyes, right? So this is, I am sure I have seen many, hopefully you can see also. Right, we'll move to the next. All right, very good. Now see these two videos, this lady and the elderly gentleman. Actually, elderly gentleman presented to a surgical ward with urinary retention, and in the ward developed these abnormal movements, and the surgeon referred to me while, this is Kurunagal actually, while I was in Kurunagal. Now try to fit, I told fight hyperkinetic disorders. To fit, to which condition this fits into? Very simple. Sorry. Does it fit into any? If not, Very bizarre, isn't it? Very bizarre, very difficult to come to a diagnosis. Movements are everything there, right? I'm sure Udayangani knows the diagnosis, as she says. Right? Now, when I was looking at him, looking at me and doing some movement, this is, anybody? Functional movement disorders, right? These are functional. Very bizarre, you can come to a diagnosis. There are a lot of diagnostic criteria for that. But my message is don't diagnose functional movement disorders or functional disorders at the first sight. Actually, Dr. Jagat Vijayasekara told me once, to diagnose a functional disorders, you have to have gray hair, right? Hope you what you mean, right? I have a couple of them, so I think I'm suitable, not jumping. So always exclude the rest and come back, right? So it's a functional movement disorders, very bizarre, right? So what is this? We are almost there, yeah, 1 minute to go. It's very regular, isn't it? Very rhythmic. So it's a tremor, isn't it? But can you maintain a tremor like this? Like so, this is again a functional tremor. All these what I described, dystonia, all have functional component as well. This always consider functional. There are two things you can do. One thing, when you distract, this goes off. When you ask the patient to count 100 downwards, trying thinks about that, it goes up, again comes like that. You can distract. And entrainments, you can do with you, ask the patient to tap like this, the patient completely forgets it. If not for a doctor, right, go ahead and see. So it's a functional tremor, this one. The last one. Okay, what is this? No history at all. Looking at, I think enough information is there. Yeah, just 15 seconds. What is the investigation I am attached to? The patient is EEG. Okay, so you know, EEG is doing for what? For epilepsy, right? So what you need to see whether this is epilepsy or not. Usually EEGs are these days ordered for your abdominal pain. That's a different matter, right? Right, very pelvic thrusting, hyperventilation, very odd movements, right? Eyes tightly closed. So this is so though movement disorders are such, I want to finish it with that, is a pseudo seizures. We don't call it, with some respect, we call it as now non-epileptic attack disorders. So thank you very much. I'm on time. So this is just a marketing part of me. We are having an annual congress in next February. Thank you. I'm sure if there are any questions, time is up here. Thank you.
We are happy to entertain one or two questions. Okay, thank you. Dr. Darshana will speak to you all later if there's question. Since there's
All the questions, so I don't.
mainly, Dr. Darshana, what do you think, like functional, which is most common thing we see, mainly the functional movement disorders sort of many times. So what is your advice? So
that's one of my advice. Don't jump into the diagnosis, right? Don't jump into the diagnosis. Always consider, because sometimes we have seen in 1920s and 30s which were diagnosed as functional. Later they have found this as dystonia, genetically transferred of genetic. So jump into the diagnosis. The clinical tool is always go to the basics and see whatever I described. Whatever I described, the various definitions, whether it's fit into that. If doesn't fit into that, yes, then think about that. Other thing is there are a lot of maneuvers you can do as a distractibility. When you distract the patient, put in some stress, ask the patient to name the days of the week backwards, like that, then the patient stressed up, it moves, goes up or reduced or whatever, right? So then entrainment, a lot of features are there. If you are interested, there is a diagnostic criteria for functional movement disorders. You can go ahead. What I want to basically tell is here is, neurology is very simple. These are all. Have I done any investigation of this patient? No. Maybe the etiology, yes, but for diagnosis, nothing. These days, what you do, you jump into MRIs and other things. No need, right? What you need to do is very simply understand the basics. Very simple. That's what I want to give the message.
okay, thank you very much.
Thank you so much, sir.
There's another one question. Yeah.
Yeah.
Sure. Yeah, good question. Actually, why I'm sure you are asking, many of the hemifacial spasms are now patients are being requested for MRIs and other things. If you suspect like this, the patient comes with very acute onset, hemifacial spasm. Then you have to think why the patient is acute onset. That is why I'm saying clinically is very important. Then you might think about, right? Rapidly progressive, yes, like that. Otherwise, from my point of view, if I come across about 10 patients, out of 10, I am 9 for 9 patients, I'm not arranging anything, right? If other thing is the clue is, if there are any other associated neurological signs in addition. For an example, is a upgoing plantar in this patient on the same side, you have to think something else, right? So spastic, maybe the brain or the spinal cord is involved. So likewise, otherwise, most of the patients you don't go for imaging. I'm sure we very rarely order. I'm sorry, in that aspect, radiology is not that much important, but very important in neurology, right? For M facial spasms, no. But I have seen many being ordered, right?
Okay, then.
Okay,
Thank you very much.
Thank you so much, sir. I would like to call upon the chairperson, Dr. Champika Gunawardena, to present the token of appreciation. And I also cordially invite the speaker, Dr. Darshana Sirisena, to come up to get the gesture of gratitude. Thank you so much.